One of the main criticisms in the report by the Department of Justice on the use of force by the Albuquerque Police Department was how officers treat people with mental health problems. A number of fatal shootings involved victims with mental illness, and many proposed reforms in the recent consent decree between DOJ and the city focus on improved training and boosting resources. NMIF producer Megan Kermick talks with members of APD's crisis intervention team and mental health advocates about what effective reform might look like.
I'm joined today by Lieutenant Glenn St. Onge. He's supervisor over the crisis intervention team and the crisis outreach and support team at the Albuquerque Police Department. Dr. Niels Rosenbaum, is a psychiatrist who works with APD's crisis intervention team. Lisa Simpson is an attorney and technical advisor to adult detention reform coordinators in Bernalillo County.
That's right.
And Nancy Konigsberg is executive director?
No, legal director.
Legal director of Disability Rights New Mexico. Thank you all for coming to talk with us today.
Pleasure.
Lieutenant St. Onge, let me start with you. Let's just start with a brief overview of the crisis intervention team, the crisis intervention unit, and the crisis outreach and support team. It's called COAST at APD. What are they? What are their roles?
The Albuquerque Police Department, we modeled our program after Memphis Police Department. They were the first to start back in 1988 with a crisis intervention program for officers who were dealing with individuals living with mental illness that officers would have a lot of contact with. APD started their program in 1997, so we've had it for a significant amount of time. And shortly after that, retired Sergeant now Gene Pettit started a crisis intervention unit, which would, if officers were dealing with someone out in the field, there was no follow-up intervention. So they would write a report, it would get forwarded to a detective, and then that detective would go out and do a follow-up on them to make sure they're linked with services and to try to avert any further negative interactions with police. Shortly after, we had the tragedies here with Duck Pham and Sergeant Carol Olasak, and then as well as after the John Hyde incident, we started the COAST team and also brought a psychiatrist on board. So the COAST team is comprised of civilians who do that intervention and follow-up on people who aren't necessarily, I don't want to say violent, but they do all the other follow-ups that the detectives don't do. So it's a pretty robust program.
So the CIT, I mean, how many people do you have in your unit?
Traditionally, we would hover around 125 people, or I'm sorry, 125 uniformed officers, which...
that means they have training.
Correct.
CIT
They're CIT certified, which means they've gone through the 40-hour certification course, and that was for uniformed officers.
Okay.
NAMI had recommended a long time ago that 25...
It's the National Alliance of...
For mental illness, yes. NAMI had recommended that 25% of your uniformed officers be CIT certified, and we hovered around that for several years, and then now we're up to over 300 certified officers now. We just finished another class last week, so...
Because the goal right now is to get every uniformed officer?
Every uniformed officer.
That training at 40
yes,
hours.
by March we should have 100% of the field officers, meaning uniformed, CIT certified.
But in terms of the CIT, the team, like the core team, you don't have very many people, am I right?
No, as of right now I have 3 detectives, myself, Dr. Rosenbaum, a sergeant with the unit, and then 6 COAST specialists.
Okay, so that's not very many, like with a highly specialized training. Beyond the 40 hours.
Correct.
Okay. So they don't go out necessarily on every call. They might go out after, like following up the officers that go out.
Primarily the way the structure was set up is we do all the follow-up intervention. That something happened out in the field. That's our main goal.
Okay. And Dr. Rosenbaum, talk about your role as a psychiatrist with the team. You're training folks?
I participate in a lot of different things. So one of my primary things that I do is do the follow-up with the detectives. So people will call the police about anything, including mental health. So if there's somebody in front of your home or your neighbor or your store and they're acting bizarrely and you're concerned about them, people call the police.
Right.
And so what the police do is they send out a CIT field officer, in a uniform and in a car, and there's no laws being broken, so there's nothing that they can intervene on at that moment. So they will refer that case to our unit, to the detectives and or the civilians, and we'll decide to follow up on that case. And if it is a high potential for any kind of violence, it'll go to the detectives, who are the police officers. And if it isn't, it'll go to the civilians. And I support both of them, so I'll do follow-up with either of them. And I also work with St. Martin's and Healthcare for the Homeless, and we staff with APS. So we'll help anybody who has mental illness, from dementia to schizophrenia and everything in between.
And so that's what I was going to ask, the common things that officers are going to encounter. People
Yeah.
having hallucinations?
There
or
is, I mean,
suicidal?
you can speak more to that than I
Okay.
can, but there's many people, as there are people. I mean, there's many things, anything can happen. So the frontline officers aren't there to diagnose, to decide what is it. That's why the CIT detectives and I are more follow-up.
Okay.
We're not going out and diagnosing people. That's not our job.
Okay. Nancy, I want to turn to you for a moment. As we know, a big focus of the report by the Department of Justice focused on the interactions between APD and people who have mental health issues or disabilities. Talk about some of the concerns that people have that you work with who might have these issues, or their families, when they might encounter the police.
I think the fear has become the excessive use of force. As everybody around this table knows, people with mental illness may not immediately comply with an order. So you get into this notion of contempt of cop. If a person has something going on in their head and has a different view of the world, simply being told to stop or stand still or put your hands up or hands behind your back is not something that they'll necessarily comply with. And one of the good things about the changes is it recognizes the distinction between, actively resisting as opposed to what's called passive resistance. If the person isn't assaultive, maybe saying something, maybe grimacing, that's not actively resisting. So I think historically, there, according to the report and what people in the community have talked about, there has been an overreaction and people have gotten hurt, tased, or killed when they haven't been actively resisting or threatening the safety of an officer or somebody else. So I think that's a huge piece that the report talked about and gave lots of examples of some pretty sad situations that had occurred.
Well, and this goes to, even though you all do a lot of training, the DOJ pointed out, we also believe that the way officers have communicated with or failed to communicate with individuals in mental health crisis shows a clear lack of appropriate training on mental illness. So do you think that these are officers you just haven't gotten to yet, or they need more training? Or?
I'll be happy to answer
Okay.
that. I think the officers I work with are amazing. They're well trained. They're incredibly good at talking to people. I got trained for 8 years, and it's hard. I mean, so it's not an easy skill. So the 40-hour training is an important thing, and it does help a lot. But this is really a societal problem. This is not, let's train cops to be doctors. This is, let's find better resources in the community so cops can be cops. And that was the reason I was hired, is so that I could help alleviate some of the burden, and that was why COAST was designed, was to alleviate some of the burden from police officers so they can do police work as opposed to social work and mental health work. But the reality is that that's what police do now, and that's why we're trying to make it as productive and safe as possible, and we really are doing that. I think the police department does a great job now.
Well, speaking to resources, Lisa, I want to turn to you. You've been working with Bernalillo County on issues of overcrowding at the Metropolitan Detention Center and mental health services. So right now, our Metropolitan Detention Center, like a lot of jails and prisons nationwide, has a lot of people suffering from mental health issues. What does that mean for the folks who, that's where they wind up, in terms for them and also for the county in terms of our costs?
Well, I want to start by saying that the county has certainly focused a lot on the detention center. It's a huge part of the county's budget. But the county also has an interest just in the welfare of the citizens of the county. And so we definitely want to see there be appropriate behavioral health services in the county, just because that needs to happen. But it has had a very large impact on our jail. Depending on how you define the mental illness, probably about half of the people in the jail have some level of mental illness. Probably around 20% have what might be defined as a severe mental illness. It tends to be a much higher rate among women than among men. And they end up there for a variety of reasons. In some instances, they're in crisis in the community, and an officer encounters them and is legitimately concerned about their safety or the safety of the people around them, and they don't have an alternative for where to take them. And they don't want to leave them on the street where they may be endangered. They can be charged with something. It often is a very minor offense, but it's enough that they can be booked into the jail and will be safe. It's not a good place for people with mental illness. We do have very good mental health services in the jail, but the jail setting generally is not a good place for people with mental illness to be. They decompensate, they lose whatever support systems they have. And so the ideal is, of course, to have the appropriate services in the community so those people don't end up in jail. Or if they're in jail, when they leave jail, they can be connected to appropriate services so they don't recidivate and return to jail.
And right now, Nancy, we're facing a big gap in those services.
A big gap. I think everybody around this table will acknowledge that. And there have been a couple of studies recently identifying what the gaps are, and the gaps are the intermediate services. I mean, we have the options of last resort, primarily the jail and UNM Hospital, and to a certain extent, much lesser extent, Caseman. So what has happened in my perspective, and I think others would agree, since managed care became the way we manage health care, the middle has certainly fallen out of behavioral health services. So there were day programs available. Psychosocial rehabilitation was much more robust than it is now. There were drop-in centers. There were something that we're desperately needing, and Lisa can speak to this more, is appropriate housing for people with mental illness. There was supportive housing. There was, what one might call transitional housing,
Where they get supports while they're in a stable situation.
Right, exactly. And there were several very good programs to that extent, so that there were places for people to be, and there were places for people to go, and there were places that would be, if you would call the soft handoff after somebody left the hospital. Now a person can leave the hospital and they'll leave with a prescription and an appointment weeks later, and a lot can happen in that short period of time.
So right now, the police encounter someone. We've got the MDC, we've got the ER if they really need something. Lisa, you're working on something called a crisis stabilization center, a triage center. What would that look like?
We are working on that, and my role is primarily to bring people to the table, like Dr. Rosenbaum and Lieutenant St. Ange. Almost called you Captain. And to facilitate the discussions among the people that there are the stakeholders in the community. So as a community, we design what this looks like. And it's also important to think of this as sort of a spectrum, a continuum of crisis response, and not just one facility, because we have to have everything from the very beginning, the community engagement teams, the mobile crisis response teams, the crisis triage, and then we have to have the services on the back end that they can be connected to. But what a crisis triage or stabilization center is a place where the police, potentially family members, potentially service providers in the community can bring somebody who's in crisis, who probably won't meet the criteria for inpatient care, but is not safe on the streets. And they can be triaged there, determine what their issues are, get them stabilized. Maybe it involves medication, maybe it involves some substances moving out of their system. And then they can stay long enough to be connected with services in the community so they can maintain their stability once they leave that center.
Now, there's been a lot of national press about a center in San Antonio called the Restoration Center that is a model like this, I believe.
It is like
saved about $50 million.
Right, and these centers exist in various parts of the country, and pretty much everywhere they've seen seen savings in both reduced use of ERs and reduced use of jail, reduced demand on police services, and so there's savings all throughout the system. San Antonio has a very good center. It's quite large. It's probably larger than what we will aim for initially, but there are other centers, Tucson, Phoenix also. There really are a number of these centers throughout the country.
And you, Lieutenant St. Onge, you all will be going to Tucson to look at their program?
Yeah, we're going to try. I think they were looking at January 13th, 14th, and 15th to go out and do a site visit. And it's something we talked about with the Behavioral Health Task Force that we would love to go, whether it's San Antonio, Tucson. We looked at several models that, hey, it'd be nice to go out and look and see what they're doing, how that integration is with police departments, with mental health providers, beds, stuff like that, and how that could benefit Albuquerque.
So one thing that for instance, the San Antonio Center has, when we talk about resources, they've got a squad of 6 officers, and all they do is go to call-outs that involve someone with a mental health issue. So going back to the training issue we talked about, the DOJ report's very complimentary to your team, and it says that APD could involve CIT a lot more. Now, you don't have that many people, but it's said in the report that if officers encounter someone in mental health crisis, they can call for a team member or a specially trained patrol officer assigned to their part of the city. There's no guarantee that either will be available. And it notes that officers aren't always conversant with the functions of your team, or they might not understand. Maybe some of the tactical teams like SWAT, I don't know if that's something as we go forward with reforms you can overcome. Is it a matter of more manpower? Is it?
I think really the biggest issue is the staffing levels. Unfortunately, the department's down, several hundred officers where we should be as far as our numbers. As far as not knowing exactly what we do, we actually teach the cadets in the academy. We go in and tell them what we do, how they can utilize us, as well as the cadets get 56 or 58 hours of a mental health block in the academy, which we help facilitate.
And will they get repeated training going forward?
Yes.
Maybe
yes.
Every year, or if there's an incident that they were.
Yeah. Actually, House Bill 93. We kind of addressed that with House Bill 93. We helped.
That's coming up in the legislature, or
No, that's already
passed. Okay.
Yeah. That mandated every 2 years, officers from chiefs and sheriffs down, including dispatchers, get a mental health block as a refresher training. The way it used to be was you go through your academy and say you get, a crisis intervention team certified in 2000. You didn't have any other follow-up training after that.
Okay.
So House Bill 93 addressed that, as well as certain incidents that happened. We would do an hour of refresher training in MOE, or was it maintenance of effort? Every year officers have to go through mandatory training.
So I think part of the reforms in the consent decree going forward is there's going to be a staffing study that
Yes.
could result in maybe your team getting more people, if that's
Yes,
thought to be part of.
Yeah, I believe the settlement agreement addressed at least a minimum of 12 detectives be assigned. That could change after the staffing assessment. It could be 6 detectives or 15 detectives, who knows. We've talked about in depth about what you're talking about is a group of officers responding to calls, and that's all they do. Kind of that's what we do now with certifying everybody in CIT. There will always be a CIT certified officer responding to a call, when we get to 100% in March and April. But what San Antonio's model is more of what we discussed as a mobile crisis team, which there's 2 sides of the fence. One side is it's only clinicians responding to these crisis calls, and I believe Portland has a very good model that's worked. It's an officer and a clinician riding together, and that's all they do. So if a crisis call or something comes out, that mobile crisis team gets dispatched, where it kind of alleviates the field officers from taking those calls, whereas you have your specialized, more trained officers taking those calls. And that's something we've really looked into.
Really? So you'll be looking at that? Because it seems like you've done a lot of training so far, but we still have all these instances from the DOJ reports. So it seems like there needs to be a shift of some kind, whether more staffing, more training. the triage center.
More resources, definitely.
Yes, more resources.
But that also goes back to what we were talking about before. Pointing and saying that the police have to change what they do is not really the answer. I think it's a community.
It's a lot of things.
As part of the community, we're going to help. But to say that we're going to change it is not the
I think there's
full
actually
answer.
two parts to that. First of all, I mean,
I'm going to give you the
it's,
final word.
yeah, it's been by default that the police have picked up this responsibility for all the reasons that we've mentioned. So our hope would be that as this transition takes place and as we bring up services, that the police could, as Neil said, go back to policing, which we need desperately, and that the response in the community be by trained mental health professionals, because it's a healthcare response. I realize that there's going to be some overlay, and I think that's a really important thing to do. And in addition to that, when there are encounters, that the de-escalation techniques that have been learned, and recognizing that not every person saying no is something for which an aggressive use of force is necessary. So I think it's a combination, and hopefully over the course of the next several years, with changes and hopefully with more resources available, that police can do what they're there to do, which is to respond to criminal activity, and that behavioral health professionals and other healthcare professionals can be responding to a welfare check, a call for assistance, or whoever happens to be on the street that people are concerned about. It would be nice to get people back into the roles that they were trained to do, which would make life a little bit less scary, I think, for family members and people with mental illness.
Well, thank you all for talking with me. I really appreciate it.
Thank you.
Thank you.
Thanks.